Okay, so this is the rest of chapter 3, so what we didn't get to go over in class today. So after watching the video on cocaine's effect on the brain, let's talk about how cocaine produces the euphoria, which remember is the high, right, or the pleasurable effects that are associated with using it. So as you hopefully remember from chapter 2, when we talked about how neurons communicate with one another, remember that there is a space between two neurons, so the synapse or the synaptic cleft. So we've got two neurons that are demonstrated here. So that space between two neurons means that the neurotransmitters, okay, so those neurotransmitters, those chemical messengers, that those need to cross the space between the two neurons. Okay, so remember that those neurotransmitters then bind with the receptor sites, which is the receiving sites on the receiving neuron. And whatever excess neurotransmitter there is sucked up like a vacuum cleaner in the first neuron, okay? So these little red dots here are neurotransmitters, and the first neuron basically kind of sucks up, just like a vacuum cleaner would, whatever is left over. So whatever there is in terms of excess neurotransmitter. So with cocaine, what happens then is cocaine blocks that process of what we call reuptake. So reuptake, this process of reuptake, is basically the process by which that extra neurotransmitter gets sucked up by the first neuron and recycled so that it can be used later on. So cocaine essentially stops that process of reuptake. So that's what you see demonstrated here. It blocks that process. So there is all of this excess neurotransmitter just kind of hanging out here. So hanging out in that synapse. And so what happens then is that the neurotransmitter, in this case, dopamine and norepinephrine, there's so much excess neurotransmitter there hanging out. So as soon as one of these neurotransmitter molecules is absorbed by the second neuron, there's another one right there to take its place. And so that blocking that process of reuptake is what then essentially produces that pleasurable high, because the neurons are being flooded with that dopamine and norepinephrine. So after this process of blocking the reuptake is over, essentially what happens, the user experiences the low or the crash as a direct result of that. So that's how cocaine produces that high in the brain. All right, so our last category then of psychoactive substances here are depressants. So depressants, they depress or they slow down activity in that central nervous system. So alcohol is an example of a depressant. So in small doses, alcohol can actually function first as a stimulant, but over time what happens with repeated exposure to alcohol, we actually see that alcohol slows down activity in the central nervous system. Thus, it is a depressant. Barbiturates are other examples of depressant drugs. So barbiturates, so Nembutal, Seconal, and Amutol, if you've heard of these before, they're typically associated with sleepiness. So people will oftentimes pair barbiturates, so sleeping pills, sedative kinds of pills, pair those with alcohol, and that can be a really dangerous combination because then you have two, right? So then you have two of those depressants that are being paired together, which can of course produce dangerous effects. And then the other one here is opiates. So opiates derive from the opium poppy. So opiates are chemicals that are specifically derived from that opium poppy, which is a flower. So morphine and heroin are both opiates. There's also opiate painkillers. So if you've heard of like OxyContin or oxycodone, those are examples of painkillers that are in the opiate family. So the common thread among depressants is that they typically lower levels of anxiety. So they can be like anti-anxiety kinds of medications. So think like Xanax could be another example. They typically reduce tension and reduce inhibitions and produce feelings of relaxation. So oftentimes they are used, at least for opiates, they're used for pain relief, but they can also be used recreationally, right? And they have a very, very high potential for abuse, as you are probably already aware with our opiate painkiller crisis going on right now. So our last category then here of drugs, let's talk about hallucinogens. So hallucinogens, sometimes you'll hear them referred to as psychedelic drugs. Hallucinogens have hallucinogenic effects. So remember, a hallucinogenic effect is to produce a false sensory experience. So false sensory experience, so this can be an experience related to any of your five senses. So false visual perception, you see things that are not there. Auditory perception, you hear things that are not there. There could also be, though, olfactory perception or hallucination, so you smell things that aren't there. Gustatory, which deals with your sense of taste, so tasting things that are not there. And tactile, which is feeling things that are not there, so like feeling things on your skin, maybe feeling like there are bugs crawling on your skin, for example, when there in fact are not. So hallucinogenic drugs or psychedelic drugs, if you've heard of LSD, acid, that these had their heyday in the 1960s and 70s. So LSD is synthetic. A naturally derived hallucinogen, psilocybin, comes from mushrooms. So your body basically processes this as poison and then produces the hallucinogenic effects. Your book classifies marijuana as a hallucinogen, but just know that not everyone puts marijuana into the hallucinogenic category, but your book does, so that's where we are. So for marijuana, then essentially what happens when you are using, you have typically an increased sensational awareness, reduction of impulses. You typically feel good, right? The euphoria, the high that comes with that. And then our last one here, lack of ability to sense satiety. So that basically means that you have a hard time knowing when you're full, meaning you've had enough to eat. So you've heard of the munchies, right? Yes, that's where it comes from when we're talking about marijuana. All right, and then if we think about the influences that can lead to drug use, sorry, my dog just is shaking here. So influences leading to drug use. So this is taking it back to that biopsychosocial model that we talked about way in the beginning of the semester. So remember that psychologists look at trying to explain, why do people do what they do? Why do people think the way that they think? By using those biological, psychological, and sociocultural influences to try to put that puzzle together. So if we think about a biological influence on drug use, so for example, we might note that there are genetic predispositions. So for example, something like alcoholism, so being dependent on alcohol, there appears to be a genetic component to that. So you may have noticed that problems with alcohol run in families. And so we know that there is some genetic component. But remember, predisposition does not mean it is inevitable. So predisposition makes it more likely that you will develop a problem with alcohol, but it does not mean 100% you absolutely will. It just means that it increases the likelihood. We also can look then at the psychological piece. So individuals who seem to lack a sense of direction, lack a sense of purpose, who are under high amounts of stress or who have other psychological disorders like depression or anxiety are at higher risk for using substances. So oftentimes people will talk about, oh, you know, it's been a long week, I need a drink. Well, that's an example of using alcohol to deal with stress, right, as like a coping skill, and it's not a great coping skill. We'll talk about that more in chapter 12 when we get into stress. Additionally, we find that for certain psychological disorders, so depression and anxiety, that people will often self-medicate, meaning that they will use the drug as a way to treat the problem, right? So use the drug as a way to potentially feel better. And then finally, looking at our sociocultural influences, we find that people who live in an urban environment, there's typically greater access to substances, so that can be a risk factor here. But we can also look at how does the culture view use of particular substances. So here in the United States, drinking alcohol is seen as, you know, something that is for rebellious teenagers, right? And for, people under the age of 21, that this is a rebellious kind of thing, because it's prohibited, right? Unless you're 21. But in other countries where alcohol is not viewed in quite the same way, so Germany, for example, where technically 18 is the drinking age, but there's a lot of variability in that, we typically then see that teenagers don't treat alcohol the same way that they do here in the United States. We also typically see in continental Europe that there are much lower rates of alcoholism than there are here in the United States. So perhaps our kind of cultural view of that particular substance might be influencing that. All right, so that's all we have for chapter 3. I'll see you guys on Thursday. See you later.